real quick, go over drug metabolism. So if you've taken medchem, you do know what pharmacokinetics are, hopefully. And so the basics of pharmacokinetics is that is what the drug does to, what your body does to the drug. So you have your ADME properties, which is absorption, distribution, metabolism, and excretion. Absorption is like how the drug gets into the body. Distribution would be where the drug goes in the body, whether it's being deposited in the brain, in fat, in muscle, into an organ, stuff like that. Metabolism is how the drug is broken down in the body. So we have a star by that because that's what we're really going to focus on in terms of pharmacogenomics. And then excretion, so how the drug leaves the body. It's usually through the kidneys or through fecal excretion. So for the ones who took medchem, you guys know what a prodrug is still? No? Okay, wow. It really stuck, guys. So prodrug is basically, usually when you have a drug that goes in the body, it gets in the body, it does this thing, it gets metabolized, it leaves the body. Prodrugs are really weird. They need to be metabolized first before they're active. So I'm not going to mention prodrugs a lot in this lecture. It just kind of throws a wrench in everything. But just so you guys know, what I'm talking about is not applicable necessarily to all drugs. Sometimes pharmacokinetics can differ based on how a drug is activated. And then, so getting into metabolism, there are two phases of metabolism. You have phase 1 or phase 2. So phase 1 is going to be your small molecule drugs. So phase 1 uses enzymes to alter or introduce functional groups via oxidation, reduction, or hydrolysis. So that organic chemistry never goes away if you want to continue in medicine. So that's going to, like I said, going to be your small molecule drugs like acetaminophen, a small molecule drug. And these are drugs that can pass through cell membranes and have some function in the cell. And this actually does make up most of our drugs. If you can take a drug by mouth, as in like a tablet form, that is a small molecule drug. Some large molecule drugs can be taken by mouth, but it's not common because they will typically be broken down in the stomach. And then you have your phase 2 metabolism, which that uses endogenous molecules to form a conjugate with the functional groups. And these, again, are going to be large molecule drugs, so like biologics. Those are going to be your large peptides, your monoclonal antibodies, large xenobiotics, all that kind of stuff. So an example would be adalimumab, which is Humira, if any of you have heard of it. Any drug that ends in mab is going to be a monoclonal antibody. That is going to be a biologic and a large molecule drug. So these do tend to be injection medications, and they do work outside the cell. So going over what enzymes and what molecules work in metabolism, for phase 1 it is mostly CYP enzymes, which are cytochrome P450s. I know Burwell will go over cytochrome P450s till she's blue in the face, so I'm sure some of you have at least heard that word. As you can see, it's broken down into the different cytochrome P450s, so anything that starts with that CYP is going to be a cytochrome enzyme. And then phase 2 is, again, your larger things, so it's going to be largely UGTs, which are involved in glucuronidation. So basically, they're going to make molecules that can be excreted in urine that are like negatively charged, hydrophilic. It's going to take a sugar, add it on. And then your sulfotransferases, which are involved in, they form a sulfate conjugate to allow, again, for renal excretion as well. So those are your main two with phase 2 metabolism. So in terms of cytochrome P450 enzyme, because that's what we're going to focus on today, these are some of the most common ones. CYP3A4 is the most common cytochrome P450 enzyme. And the way drugs can interact with cytochrome P450 enzymes is they can be broken down, they can inhibit the enzyme, they can induce the enzyme, which gets really fun when you have, for example, rifampin is a 3A4 inducer, a really strong inducer. So if you co-dose rifampin with another drug that needs to be metabolized by CYP3A4, because it's induced, you're going to end up with that drug out of the body much quicker. So you have to pay attention to that, and that's part of what I do in pharmacy. And then you have 2C9, 2C19, and 2D6. 2C19 and 2D6 are the two that I'm going to focus on today. And now that we've gone over drug metabolism, let's go over some antidepressants. Hopefully, most of you are not familiar with antidepressants. If you are, I'm sorry. So some types of antidepressants. You have your SSRIs, which is your selective serotonin reuptake inhibitors. Those are going to be the ones that most people know about. So some examples are sertraline, which is Zoloft. So I have the generic name and then the brand names in parentheses. Citalopram is Celexa, and fluoxetine is Prozac. Then you have your serotonin and norepinephrine reuptake inhibitors, your SNRIs. So that's venlafaxine, which is Effexor, and duloxetine, which is Cymbalta. Then you have your tricyclic antidepressants. So nortriptyline is Pamelor, and amitriptyline is Elavil. And then you have your other. They're kind of just classified as other because they kind of sit on their own. They're structurally similar to other ones, but they don't really fit in the same drug class. So that's going to be like bupropion, which is Wellbutrin, and mirtazapine, which is Remeron. So when you look at the different drug classes for antidepressants, they can kind of be used for different things. For example, SNRIs, they're going to work on serotonin and norepinephrine. Norepinephrine, as some of you may know, is involved in like your fight or flight response. So if someone's having a lot of panic, their moods are kind of going all over the place, and they're experiencing a lot of that fight or flight response, they might benefit from an SNRI rather than an SSRI. Bupropion works on norepinephrine and dopamine. So if someone's having some psychotic symptoms, so like delusions, hallucinations, stuff like that, bupropion might be a better one for them. And then mirtazapine is a tetracyclic antidepressant. It also works on serotonin and norepinephrine. It's just structurally kind of in its own class. So that's just a really quick overview, and then I just have the label for sertraline, like if it came in like a box. Let's see. So the antidepressants we're going to talk about today are citalopram, escitalopram, fluvoxamine, paroxetine, amitriptyline, and nortriptyline. I have the CYP enzymes that are associated with each one. As you can see, it's either CYP2C19 or CYP2D6. Amitriptyline is a fun one because it's both 2C19 and 2D6, so when you have to look at the pharmacogenomic applications of that one's really fun to do. So why antidepressants? Why do we care about antidepressants when we're talking about pharmacogenomics? So as I'm sure some of you guys know, so many people are on antidepressants nowadays. The prescribing rate for antidepressants has actually skyrocketed since COVID, which is not really a shock, but it has happened. It is now one of the most commonly prescribed drug classes. And with antidepressants, it is a lot of trial and error. So they take about 6 to 12 weeks to take full effect. You can see some effect in about 2 to 4 weeks, but if you want to see that full effect, it really is going to can take up to like 3 or 4 months. So that trial and error period is very long. So let's say a doctor prescribes someone sertraline. It's going to take you 3 or 4 months to figure out that drug might not be working. And that's a very long time to take to figure that out. So what pharmacogenomics can do is it can help guide providers to a more appropriate selection on the first attempt by looking at what your genome says about how you might metabolize the drug. And then given all of this does make it one of the most common pharmacogenomic applications in the community setting. Another really common application is cancer, but that's not so much of in terms of community setting, that's more in a hospital setting. All right, so now we will go into what is pharmacogenomics. So you have 4 different types of metabolizers that you can be in the body. So you can either be a poor metabolizer, so you're going to break down the drug very slowly. So if you're breaking it down very slowly, you are going to have that drug sit in your body for a much longer period of time than you're expecting. You can have an intermediate metabolizer, so you're still breaking the drug down pretty slowly, but not as slowly as a poor metabolizer. Your extensive metabolizer is just another term for normal metabolism. Breaks down the drug just normally at normal doses. And then you have your ultra-rapid metabolizers. So that is when you're breaking down medication very quickly and the drug does not stay in the body as long as you were expecting it to. So from this, you can kind of infer where we're getting at here with dosing. So if you're a poor metabolizer and we give someone if someone's a poor metabolizer and I give them a normal dose of citalopram, they can experience serious adverse effects at a normal dose because that drug is sticking around in the body for a little too long. So you're just getting more of it than you're expecting. Intermediate can be kind of a gray area. You can be fine as an intermediate metabolizer. Sometimes you might need to change something. It kind of just goes by patient, by drug. And then ultra rapid, that is basically the drug's getting in the body and it's getting out and you're not getting the effect that we need you to get. So as you can see, that's not great because if we give someone a drug, we want it to work and do something. And then going from there, we need to discuss enzyme allele activity. So this is where we get more into the genetic component. So as you saw on my other slide, every CYP enzyme has that CYP, and then it has a number, a letter, and then another number. So that CYP just infers that it's a cytochrome P450. The first number indicates the family, the letter indicates the subfamily, and the third number indicates the individual cytochrome that it's part of. So an extension of that is you can further classify them by their allele type. So that is notated with a little asterisk followed by a number. So for example, CYP3A4 star 1 would indicate a, star 1 indicates a normal metabolizer, which I'll go into a little bit in the next slide. But so that's what you would see there. You will not see this in general write-ups about CYP enzymes. You will just see the CYP3A4 because your alleles, as you all should know, are different for every person because you get them from your parents. And the allele is actually what determines the medication, right? So when you have to look at that star number to determine are they a poor metabolizer, ultra rapid, stuff like that. Okay, so the star numbers. Every drug has their alleles associated with them, and every drug is different. Typically, the one that you're going to see the most is star 1, usually indicates normal activity. To my knowledge, I haven't seen it indicate anything other than normal activity, but again, there could be something I just haven't seen before. So in this chart, you can see CYP2D6 and all of those, the alleles associated with the different types of activity, so increased activity, normal activity, decreased activity. And then you also have your no activity or null alleles. These are really fun because they can either do something or they don't, and it's kind of up in the air. So let's say, going back, you all had 2 alleles. You get 1 from each parent and you end up with 2. So when you have, when you get your genomic report, you get 2 alleles. So if someone could have an allele that indicates increased activity and an allele that indicates null activity. Sometimes that can mean that they're an ultra-rapid metabolizer. It might also mean that they're just a normal metabolizer because that null allele might be doing something wild. I'm not going to get into null alleles too much because, again, that is very nitty-gritty and not what you guys really need to know about right now. But just from this, you can see that each CYP enzyme has a lot of alleles associated with them. CYP2D6 in particular has over 100 allele variants, and there is definitely not over 100 on this chart right now. So you can definitely infer from that how much goes into this. So what does a pharmacogenomic report look like? When you're pulling all of this together, you want to see the CYP enzyme, the allele, and what this means for metabolism. So what you can do is you can get a pharmacogenomic report pulled for you. This is just an example. This is not applied to a patient. This is just made from an educational facility that just compiles them so people who are in healthcare education can learn how to apply this stuff. So as you can see from this report, you have CYP2C19 and CYP2D6 right at the top. So your genotype, again, you have 2 alleles, so it's star 1 and star 17. So from this, that star 1 is normal, that star 17 is rapid. So you can see that that makes them a rapid metabolizer, and then you also see the alleles tested. 2D6, we have star 4, so they're a poor metabolizer, and then you can again see the alleles tested. So if I had a patient and they came in and they gave me this pharmacogenomic report, let's say I wanted to give them escitalopram, which is metabolized by 2C19. Given that they are a rapid metabolizer, I would actually want to give them probably a different drug because I don't want that drug just going through the body and having to give them higher and higher and higher doses in the hopes that some of the dose might stick around because that can increase the risk of adverse events. This also differs. This is not like a cut and dry thing that you can apply to all drugs. For instance, if I wanted to give them sertraline and they still were a rapid metabolizer, I could start them on the normal dose and see where it goes from there, because just the adverse effects with sertraline versus escitalopram kind of differ. But for me, in terms of edging on the safe side, I would probably give them a different drug. Let's say I wanted to give someone paroxetine, so that's metabolized by 2D6. They're a poor metabolizer. I would still, again, want to give them a different drug. So amitriptyline is the one I talked about that goes through both CYP enzyme, that's again where it gets real fun, you have to look at both. So you have to look for amitriptyline, you look at CYP2D6 first, and then you look at 2C19. So if you look at 2D6 and it's normal, you could then move on to 2C19, and you would dose based on the result of 2C19. If CYP2D6 comes back as intermediate, then you would dose reduce by 25%, provided that CYP2C19 doesn't result in a poor metabolizer or an ultra-rapid metabolizer. So that's kind of where you get into the nitty-gritty of how does your genotype fully create your phenotype, and what does that mean in real life? Okay, so how does this all work? As you can see here, you have your standard dose. Let's say you have a medication, you give them 2 tablets. Let's say each tablet's 5 milligrams. You would give them, your standard dose would be 10 milligrams. You would give a poor metabolizer probably just 5 milligrams. An intermediate metabolizer might get 7.5 milligrams. They could also get the full 10. Extensive, that's your normal again. They could get the full 10 milligrams, and then your ultra rapid, they might end up getting 15 milligrams because they need a little more of a dose. So once you have a pharmacogenomic report, what you do is you take it and you apply it again to the drugs you're looking at and to the metabolism that's been reported. What you look at when you're determining what to do with the drug, you want to look at your adverse effect, dose customization, and precision medicine. That is very strongly used in cancer indications because we want to give someone medications for cancer that's going to kill their specific cancer and not just like hope it will kill their cancer. So in terms of adverse effect, a good example would be citalopram. Citalopram has a decent warning for causing QTc prolongation, which if you don't know what QTc prolongation is, if you look at an EKG, you have your T waves, your QRS complex, all that stuff. That means the time it takes for you to get from Q to the next T. So all of those, the little spikes on the EKG indicate some sort of electrical current that correlates to your heart actually beating. So if it takes a lot longer for you to get from Q to T, your heart's not beating appropriately. It can result in fainting, cardiac arrest, or even sudden cardiac death. So citalopram, again, causes QTc. If someone was a poor metabolizer and I was going to give them citalopram, it's going to put them at an increased risk for QTc prolongation, and it could land them either in the hospital or it could be fatal, which is, again, not what we want. For dose, antidepressants, it's really hard to find a good dose for antidepressants. You have like a starting dose and you titrate up to like what works best for the patient. So pharmacogenomics can give you a good look at where you should start. And then again, precision medication with cancer. So for instance, doxorubicin is metabolized by, or can be shunted out of the cell by PGP, which is an efflux protein. So if I got a pharmacogenomic report on someone and they had super high levels of PGP in that tumor, I would not want to give them a drug that can be shunted out by PGP because it's not going to sit in the tumor cells long enough to do anything. So that's kind of how we work with precision medicine. And this is all done in a way just to get the best effect from whatever drug you're trying to give to a patient. Okay, so as I mentioned, very different for each CYP enzyme, each metabolizer, each drug. So this is just an example of how you would adjust your dose or adjust your clinical decision making based on what your pharmacogenomic report says. So for instance, escitalopram and citalopram, those are also pretty much the same. They're just like racemic differences between those two. If you see a drug so esomeprazole and omeprazole is a good option. If you see something that starts with ES and then it's like the same thing, it's just the S enantiomer, fun fact. But so if someone was an ultra rapid metabolizer and I wanted to give them escitalopram or citalopram, I would probably pick something different that was not extensively metabolized by CYP2C19 because, again, it's just going to get shunted out of the body. So, going over a patient case. Let's say you have a 23-year-old male. Pharmacogenomic report shows they're a normal metabolizer for CYP2C19, an ultra-rapid metabolizer for CYP2D6, and they want to start on paroxetine. What would you tell them? Elliot, you have a doctorate in genetics and you're shaking your head. Okay, so basically you would tell them that they, in their best interest, it's not that they should start on paroxetine. You could give them something that's metabolized by 2C19, such as escitalopram. You could also use some other ones. And then, so when I learned about this in pharmacy school, the first time I learned about this, I was actually on citalopram for a while. And I was sitting in class, and they're teaching us that citalopram has to be, you have to have genetic testing before you prescribe it. And I was sitting there, and I'm thinking, I have never once heard of that in my life, and I've been on this drug for years. So, why does that happen? And that happens to a lot of patients. This is not a common thing that people know about, is that this should be done. So, how do you know when to test and what drugs should be tested? There are guidelines, creating bodies that will give out recommendations for what should be tested and when to test it and how to adjust it. So your main one is going to be your CPIC guideline. So that's your Clinical Pharmacogenomics Implementation Consortium. So what they do is they put out guidelines that give you how you should adjust it based on the pharmacogenomic report rather than whether or not you should adjust it. The ones that are going to give you whether or not you should adjust it or test are going to be FDA. So FDA determines what medications may be appropriate for genetic testing and whether or not it should be included on the drug label itself and the prescribing information. So what that means is if someone obtained the drug label, it would have a warning on it that says before starting this drug or before prescribing this drug, the patient should undergo some form of pharmacogenomic testing in order to have the most safe and efficacious treatment plan. The FDA has more than 20 antidepressants that they've identified as needing some form of pharmacogenomic testing before prescribing. And as you, on the bottom, you can just see this is just a screen grab from the CPIC website. All of this is public knowledge, by the way. You can just get on the FDA website, the CPIC website, and pull all of this up. So as you can see, it'll tell you the gene, CYP2D6, the drug, amitriptyline. It'll tell you the guideline, so that's what you do based on the pharmacogenomic report. Your CPIC level, which I'll go over on the next slide, whether it's actionable or not. Sometimes this, again, is the FDA label, so the FDA can determine it as actionable or not actionable, as in, yes, there's something that you can test for, but it's not really something that you would change. That definitely happens with some medications. And then you just have your research and publications that support it, because research is important and it's good to know whether the research that's been done is valid. And that goes into the next slide, which is how do you know when to test, and this is how you classify them by CPIC or FDA. So CPIC has 4 classifications, A, B, C, or D. A means that the genetic information should be used to change the prescribing of the effective drug. All of the antidepressants I've given you today are CPIC level A, so you should be having genomic testing done before patients are put on these. B is when you could use it, you don't really need to, but it might be best if you do. Some drugs can end up with A or B. It'll be like A-B, where CPIC is like, we're not sure, it's probably going to end up being an A, but it might be a B just to be safe. And then you have CPIC level C. So that just means that some published studies have shown that there's an indication for support for pharmacogenomic testing and that it might influence clinical action in some way. And then CPIC level D is there are few published studies with support for clinical action. If a drug is a CPIC level C or D, it doesn't mean they will never be an A or a B. It just means that the research has not been done to a good volume or to a good legitimacy, I guess. Not every drug will turn into a CPIC level A if it's B, C, or D, but it is a possibility. It can change over time. FDA, they have 3 levels, so just level 1, 2, and 3. So level 1 is your highest level of evidence. That's when they look at the literature, when they look at the the phase 3 trials that used to approve drugs, they're going to look at all of that stuff, and that's when you have a very high level of evidence, and that needs to be included on the drug label. So that's when they're going to go ahead and say, yep, it needs to be there. The level 2 is going to say there is strong evidence, but they're not going to go ahead and put it on the label yet. 3 is there's potential evidence, like it could be a thing, but probably more research needs to be done. And when we talk about evidence quality and research, when you use that to determine making a recommendation, it's really important that you guys understand evidence-based medicine and how it works and just the importance of looking at research. The example I always use is if you were to do a study trying to figure out rates of lung cancer and you looked at how many people buy lighters versus how many of those people end up with lung cancer, you are going to get some correlation between buying a lighter and lung cancer, but that research is not valid because you've missed something, and it's probably that they're using those lighters to smoke. So that is what I mean when you look at quality of evidence, like whether it was done correctly, whether they accounted for bias, whether they did all of that stuff. So, going off of that and going back to my further point of why is this not done, and when I said how can money actually make you happy, what I mean is this is very expensive. Genetic testing is expensive as a whole. I'm sure you guys have looked up 23andMe and seen that they're like $200 per thing. The cost of genetic testing is getting better, I will say that. Insurances typically will not cover it, which is really exciting because if your insurance doesn't cover it, you're probably not going to have it done. This is changing. This is going in a good direction. Medicare and Medicaid recently have updated their coverage guidelines regarding pharmacogenomic testing and what they'll cover. There are stipulations with it. You do have to have, prior authorizations, all of that stuff. It will only cover certain meds. It needs to be based off the medication, not the diagnosis. It's all this fun stuff. The other component that can be a barrier to having this done is time. It can take some amount of time to get a pharmacogenomic report done. And when you weigh the benefits versus the risk of getting that done, it might be more beneficial just to start a patient on a medication rather than waiting for that genomic report. So you'd probably start it and then you could get the report and then go from there, but it doesn't necessarily need to be the first step. And the other one is awareness. So pharmacogenomics is a required aspect of pharmacy school curriculum. By the accrediting body for pharmacy schools, it has to be in the curriculum in order to be an accredited pharmacy school. It is not a required aspect of any other medical curriculum, to my knowledge, unless that changed in the last few days. I don't think it has. But so if you're getting an MD, a DO, any sort of nursing degree, PA, all of that stuff, some of it includes pharmacogenomics. Some schools will, but it's not required, which means they don't need to teach it if they don't want to. So what does that mean? If it's only required for pharmacists are not prescribers, unless you're in the UK. So if let's say I'm at the pharmacy, I get a prescription in for citalopram. I could call the doctor and be like, hey, did you get a genetic test? And they could easily just go, no. And I could be like, could you? And they can go, no. And that's that, because we're not prescribers and the application would be limited to a professional recommendation. And as I was going over in the previous couple slides, this is still a relatively new application for medicine. A lot of it's still being done. So the research is kind of lacking right now. In the next few years, I'm sure there will be a boom in pharmacogenomics. If you guys are looking for a career that has a lot of growth, this is probably a good thing to look at, because genetics is, a really cool new thing right now. So where do we go from here? Improve costs, improve coverage, which is going to be based in any sort of legislation and policy change. And you can also make sure that it's being included in the curriculum. And the other thing I want to impress upon you guys is, I know a lot of what I've said is like, yep, you can do it, or you cannot do it, it's different for each drug. But this is actually very important. There have been instances where patients have died because they were a poor metabolizer of a drug and they were given a drug and they overdosed on it because no one knew they were a poor metabolizer until after they died and they'd done subsequent testing. I know there was a case in 2009 where a 9-year-old died because they were prescribed fluoxetine and they overdosed. And then you also have, there's a case in 2012 where someone died because they were given venlafaxine and they were a poor metabolizer. So this is a very important aspect of medicine. You really want to be looking at this when if you're a clinician who's going to prescribe one day. This is something you do want to keep in the back of your mind. Just because a guideline says that something is a first-line recommendation doesn't mean it will always work for your patient. Your patient is one very specific independent entity, and a guideline is very general. So that's what you have to weigh, both of those things at the same time. Medicine is very nuanced. But yeah. So these are my references. And did you guys have any questions? Yes.
I'm wondering, so what is the process for finding which disease is targeted by which drug?
That is an excellent question that I don't actually really know the answer to. I should know the answer to that, I feel like. But what do you...
Yes, you should.
what do you mean? Like, figuring...
You know, when they're screening for which genes are coding for how each drug is metabolized, like, what are they looking at? How are they finding it?
I'm finding that I might be too into the clinical game for too long. Yeah. What?
Metabolomics. So you deliver a drug, right? And you can do metabolomic analysis, things like that. So you look at the things that are up and down with regards to based on making medicines. It's not easy.
You're definitely going to be a PhD student, not a PharmD student. Sorry, I'm more on the clinical side.
Thank you.
Anyone else? Yeah.
It seemed like when you were classifying whether or not these genetic tests should be done, it was either yes, you need to do the tests, or we don't have the data.
Mm-hmm.
So how would you classify something that has been tested but has been found to be safe, and maybe you don't need these tests?
They would just not be classified at all in the CPIC database.
Okay, just not.
So like
there.
if you had a drug that really didn't need to be adjusted based on genomics, it wouldn't be really in there at all. It'd just be a regular drug that's on the market. So like acetaminophen, we're not really doing genetic tests for that because it's not really a super applicable indication for it. Yes.
I'll ask a question that you can school me up.
Oh, great.
So when you have the FDA characterization or the other organization, and they ship,
Mm-hmm.
say, based on research, who is in charge of letting the patients know that it's shipped?
That's a
Is that on the pharmacist yet again, or is it the doctor, or is there any policy?
There is really no policy. There's an aspect of if you are licensed as a healthcare professional who takes care of patients, you are required to continue your education in some way and stay up to date. What you stay up to date in might not necessarily be pharmacogenomics, so sometimes people don't know, but that's just, again, a matter of continuing education. I will say there are drugs in which CPIC and FDA do not agree. So CPIC will classify it as level A, and FDA is like, no. Or FDA is like, yeah, it should be on the label, and CPIC is like, I don't think so. So again, that is more policy legislation. It is a very gray area in terms of what happens and who should be in charge of it. I will say pharmacists are not providers. They are not given provider status. They should be given provider status. If any of you go into law and you want to do healthcare policy, please give pharmacists provider status. But so sometimes when a pharmacist makes a recommendation and is like, oh yeah, this is a new thing, you should do that. Again, the ones who are actual providers can be like, no, and that's the end of it. So it's not fun to do. It's not a very fun situation to go into. I know I've had patients in the ED I had one patient who they had heart failure. They were very poorly controlled. I went to their physician and I said, hey, their medications are not really optimized for their heart failure. Maybe we should make some changes. And they were like, I don't need a pharmacy consult. And I was like, rock on. So you kind of got to pick the hill you want to die on. Anything else?
Can you talk about what's involved in the farm program? Classwork, lab work, practical, all the above?
What was the first part of that?
What's involved in the D-Farm program?
Oh, like in my curriculum?
Yeah.
Oh, so yeah, so pharmacy school consists of, you can either do 2 years of prereqs or 4 years and get the whole bachelor's. I highly recommend getting the full bachelor's because the students who go into pharmacy school with just the 2 years, when I started just looking between how they were struggling versus how I was like, oh yeah, I already learned all of this. So like, just taking biochem before you go into pharmacy school is very important. So that would be your prereqs to go into pharmacy school. And then it is 3 years of didactic curriculum. Within that curriculum, it is a very intensive program. I take about 18 to 21 credits a semester, and that's all chosen for us, so there's really no way to like get around it. Within that semester, you also do some sort of rotations. You have a required rotation hours that you have to complete before you graduate, so that consists of your IPPEs, which are your introductory pharmacy practice experiences, and your APPEs, and that's your advanced pharmacy practice experiences. Your 4th year is all APPEs. So for my 4th year, the way Binghamton does it is we do 8 modules that consist of 7 APPE rotations that are each 6 weeks. So you need to do 270 hours per rotation, and you do that for the whole year, and then you graduate, you get the PharmD, you take the NAPLEX, the law exam, you get registered as a pharmacist. I will say, MDs have 2 years of didactic curriculum. I will again mention that pharmacists have 3 years because most other healthcare programs, they do like 1 year of pharmacology, and then pharmacists are doing like 3 years of intensive pharmacology to be able to learn all of that. So there isn't, in terms of lab work, there's not a ton of lab work. There's definitely room for research. Binghamton has a required capstone project that everyone has to do before they graduate, very similar to how Wells requires a thesis. You can either do lab research in that, you can do like healthcare statistics research, looking at how different patients are treated in the hospital. I know what I'm doing is I'm looking at pharmacy school curriculum and seeing if it adequately prepares pharmacists to go into like clinical pharmacy. So like, are we preparing students for residency? That's what I'm working on right now. That also will happen at the end of your P3 year and during your P4 year. And then in terms of other lab work, we do a skills lab, and we also do a compounding lab. So pharmacists are all taught how to make medications. So let's say we have a medication dosed typically in a tablet form the patient can't swallow. We have to figure out how to get that from the tablet form to a solution form, or even if you need to apply it topically to the skin or something. So that's another area the pharmacists are very well trained in. That also includes making IV, preparing chemo, all of that fun stuff. I don't think I missed anything.
As sort of a follow-up to that same question, you're already into biochem, taking that before going into pharmacy school. Are there other classes at Wells you think really help prepare you for like your plans and career after Wells? Maybe sciences, of course, but also more broadly?
Yes, if you are looking to go into pharmacy, or honestly anything really healthcare related, biochemistry is super important. Medicinal chemistry is very important. I know I had one class where I started the semester and everything that they had taught, I had already been taught in a mix of biochem and medchem. So that class was super easy that semester, just because I took those classes here, and they're also taught very well here because, as we know, Burwell's an excellent professor. I don't know if I can think of any other specific classes off the top of my head. Getting a good range of education is also very good because it can expose you to a lot of different things. And then research. You know, if you guys want to do research, it looks very good to furthering education. If you can go into an interview and be like, oh yeah, I wanted to do this research, so I did it, and then I did this, this, and this. Most undergrad students don't have that. I didn't know that till I left Wells. But yeah, unfortunately, you guys will not realize the quality education you got here until you leave. It won't really hit till you leave, but when you do get out there and continue your education, you see people who have gone to other larger schools where the professors can't focus so much on the students, you really will see the difference in education that you have gotten. So that is my standing on the soapbox about that. Anything else? No? Cool, guys.